And for me, I literally asked myself the question, where do I begin? Because I look at this issue from at least three different perspectives. I have been a general pediatrician. I've provided primary care to children and families over a number of years. And certainly issues with regard to early childhood mental health services and support predominated within my practice. Secondly, I am a board-certified developmental and behavioral pediatrician, have offered subspecialty and consultation services, and obviously a very strong interface with childhood mental health services. And now I am admittedly primarily an administrator at a children's hospital and in a department of pediatrics of a medical school. And so many critical issues arise that relate to childhood mental health services. So, in attempting to think about where to begin, I contemplated a host of problems based on my multiple perspectives. Clearly, within the primary care setting, there is inadequate recognition of young children with behavioral and developmental concerns, and not surprisingly, parental dissatisfaction as a result of our inability to identify children at a young age. Secondly, we're all aware of the extent to which there is inadequate capacity, inadequate program capacity and services for children with behavioral and developmental problems. And as a result, there are extraordinarily prolonged waiting times for referrals. I am embarrassed to share with you the waiting time for the assessment of a child for whom concerns with respect to autism arise in the state of Connecticut. It is unacceptable. It ranges from 6 months to 2 years. A 2-year wait when a child is suspected of manifesting signs or symptoms of autism, unacceptable. So where do we begin in defining the problem? Well, there have been a number of proposed solutions, targeted solutions to the very problems that I've raised. So, for example, the American Academy of Pediatrics has issued a policy statement in July of 2006 on early detection, specifically developmental surveillance and screening, that serves as a very appropriate, effective guide for child health providers and should, if followed, enhance our ability to perform early detection, and particularly early detection of children at risk for adverse developmental and behavioral outcomes. These targeted solutions must be part of a broader system solution. But what I'd like to do with you, coming from my child health provider perspective, is take a step back and suggest that we have the opportunity to help solve this crisis by identifying children early when we know that they are at risk for adverse outcomes, when we know that services can be brought to bear that are more easily accessible, that are less intensive, that are less extensive, and yet can prevent behavioral concerns from escalating into subthreshold and beyond psychiatric diagnoses. So to illustrate this opportunity, what I want to do is tell you the Connecticut story, our story in the evolution of the Help Me Grow program that Anne earlier introduced. And I want to try to do this in a way that it will hopefully derive implications for you, particularly given the efforts that you are about to embark on in Erie and Niagara counties. Lessons that we've had the privilege now, with support from the Commonwealth Fund, to travel around the country to at least 5 other states, share the lessons learned, and provide assistance as other states begin to replicate what we have done in Connecticut. So, Our statewide program began with a citywide initiative in Hartford. Now, Hartford is the state capital of Connecticut. Connecticut, even in the most recent surveys, amazingly, is still the state with the highest per capita income in the United States. I say amazingly because our status as number one is really driven by Fairfield County, our Gold Coast, and Wall Street. So the fact that we are still number one, and I saw that in a recent survey, is amazing to me. And actually, I find it hard to believe, given that our state budget deficit, because of the losses that we anticipate from taxing the income in Fairfield County, has now ballooned to $8.7 billion in a state with 3.5 million people. So, Hartford, the capital of Connecticut, highest per capita income in the country. There has been a promotional effort to describe Hartford as New England's rising star, and it does have its lovely sections and parts. This is Bushnell Park. However, Hartford is also, at least in the surveys that we looked at, ranked the second poorest city in the country. And in fact, Connecticut plays host to 3 of the 10 poorest cities in the country: Hartford, Bridgeport, and New Haven. The discrepancy in quality of life between suburban and urban living is overwhelmingly a problem. Overwhelmingly a problem. And in this poor city, we face all the adverse impacts on children's development that you can well imagine. The one that I've chosen to cite here is lead paint, but I just could as easily could have cited neighborhood violence, family violence, drug problems, etc. So it's within Hartford that we gathered together child health providers and other constituency groups. And in answering the question, how could we strengthen child health services to try to best promote Hartford's children's optimal healthy development, we made some assumptions. And I'd invite you in your respective communities to think about the extent to which these assumptions apply. Number one, we assumed that children with behavioral and developmental problems were escaping early detection. Well, we were not on thin ice in making this assumption at all. And in fact, one need only go into our kindergartens, first grades, second grades to appreciate the extent to which children with significant issues were escaping early detection. Secondly, we assumed that there did exist a wide array, even in poor urban Hartford, a wide array of programs and services that existed to address children's behavioral and developmental needs and support families in promoting children's optimal development and behavior. Of course, we knew that there are capacity issues. We knew that there are gaps in services. But we did believe that there were programs and services out there that could be brought to bear in addressing the needs of at-risk children. Third, we assumed, again, not a dangerous assumption at all, that a gap existed between the best efforts of child health providers, child care providers, preschool teachers, visiting nurses, social workers, and others to promote the early detection of at-risk children and the linkage of these children and their families to programs and services. And finally, we made the assumption that children and their families in Hartford would benefit from a coordinated, region-wide system of early detection and intervention for children at behavioral and developmental risk. And it was on the basis of these assumptions that we brought together a host of partners. But from the outset, we realized that if this was just about early detection, and it didn't result in linking children and families to programs and services, then our early detection would certainly be ineffective in terms of promoting the best outcomes for children. And in fact, we agreed with Ellen Perrin, a colleague of ours in Boston, that such early detection without intervention is not only ineffective, but it's unethical, because all it does is further raise parent anxiety and concern without the promise of any assistance. So with these assumptions and with this belief, we brought together a host of partners. The specifics are not important for you, but I would point out that our collaborative included funding agencies, and indeed how important they are in providing support. And for us, the Hartford Foundation for Public Giving has been a very generous and very thoughtful both supporter as well as contributor to the evolution of our program. This was a public-private partnership, and we embraced our city health department and its child development program. We engaged every child health provider across the city, pediatrics, family medicine, physicians, mid-level practitioners. We embraced our information and referral system for our Medicaid managed care system, anticipating that telephone access would be important, our so-called Children's Health Info Line. We fully engaged parents in our planning process, and recognizing the relationships between the detection of children at risk and referrals to our statewide early intervention system, our Part C, which in Connecticut is called Birth to 3, we engaged our Part C colleagues very early as partners, even in our citywide pilot initiative. The ability to provide a single point of entry for our early intervention Birth to 3 system, preschool special education, our Children with Special Health Care Needs program, and for at-risk children, Help Me Grow, is a remarkable accomplishment in Connecticut because of our admittedly parochial silo mentality. Because Child Development Info Line represents collaboration, unprecedented collaboration across 5 state agencies, including a blending of funding and a blending of administrative support. So Help Me Grow itself is a program of our state's Children's Trust Fund. The Connecticut Birth to 3 system is a program of our Department of Developmental Services. Our preschool special education program is a program of our Department of Education. Our Children with Special Health Care Needs program is a program of our Department of Public Health, and Child Development Info Line itself is operated by Connecticut's United Way agency. Unprecedented collaboration across 5 state agencies, a blending of funding streams, and as a result, Help Me Grow Connecticut, which serves about 3,500 children each year, if we include both direct referrals as well as distribution of the Ages and Stages questionnaire, which is a parent-completed developmental screening questionnaire to strengthen developmental monitoring, is operated at a total expense of a mere $650,000 a year in a state with a population of 3.5 million people. The most frequent services requested certainly reflect behavioral concerns and behavioral problems. Parents seek assistance with parenting strategies to address behavioral concerns. They seek referrals to community-based family resource centers that offer support for parenting, child care programs, and others. They seek mental health evaluations for their children, developmental assessments for their children, and as I mentioned, many parents seek to participate in the Ages and Stages program to strengthen our developmental screening, the results of which, by the way, are shared with our child health providers to assist them in their developmental monitoring within the medical home. So, in conclusion, I hope I've stressed to you the extent to which services for children with behavioral concerns have to be first and foremost informed by all that we've learned from our knowledge of early brain development and early child development. And it's all about prompt detection. Detection must lead to early intervention. Services must address the multiple factors that both facilitate and support as well as hinder children's optimal behavior and development. And we have to think about programs in a comprehensive, cohesive, system-based way. Children and families to take advantage of programs and services require outreach and support. We should anticipate the need for parenting support even as we devise programs that we think are addressing children's quote-unquote developmental needs. And it's always critically important to keep in mind the need for evaluation as we evolve new programs if our hope is for these programs to be sustained and ultimately replicated. And finally, as Charlie will demonstrate, ultimately it's all about the system, and the system will in fact enhance service delivery. Thank you all very much.